Hello and welcome to Pain Options Education. This is the place for discussion on topical issues in musculoskeletal pain, for a common sense take on current research and evidence, and to help fine tune your clinical practice. And I think I need to fine tune mine. I'm Darren.
And I'm Tim.
And are you liking our new logo, Tim?
It is. Paul's done a good job on that with his usual star.
Yep. He has. I have a lot of luck with this clicker. So we're talking about pain sensitivity. This is our first in a series of discussions around this topic, and I'm looking forward to the next few hours while we talk about this. So part one today is about why we're going to talk about pain sensitivity, and we'll start with this, and this is the results of this is the answer to a question we asked, and we can see that we've got pretty much 50% of these people agreeing and 50% disagreeing. But what did we ask them to get this kind of result, Tim?
Yeah, this was a symposium that we held 3 or 4 years ago now, maybe 5.
Maybe more. Oh, hang on, there's the reference. Yeah, 2015.
There we go, 5 years ago.
Yeah.
We held this symposium, and it was a group of different stakeholders involved in treating people with work-related pain or managing people. So it was physios, also doctors, other healthcare practitioners, and people involved in the workers' compensation sector. And we presented a typical case of someone what we would now describe as having pain sensitivity. And we presented the case around that, and we just asked a question in this instance around, in managing this person, would we need to get them to just push through their pain to get better? And as you can see there's a complete, I guess, both sides of the fence around how we should manage this person that we gave the example of.
Yeah, and I think that confusion still exists today, doesn't it?
Yeah, it does. It's a complex area, and we often talk about it depending on each individual person, and maybe that's reflective in the answers that people provided in this instance.
Yeah, maybe. Though the scenario we gave them was pretty clear that this person was very wound up, and I guess in the end we'll have an opinion on this ourselves if you stay tuned till the last second to last episode when we talk about management. But it is a tricky area.
Yes, it is.
Yes, it is. Hence why we're doing this series. So we thought we'd just start with the fundamental principles of contemporary pain biology. This comes from an article actually I was involved with a few years ago, 4 years ago, by the look of the date on it. And while I'd very, very happily quote myself here, I can't actually say that what we're about to talk about was my work, and that was Lorimer's. And Lorimer sent this paragraph, and about all I did was split it up and put it in a table and changed about 3 words, and they were like, and, it, and I. No important words. So Lorimer's kind of described these. I think there's 5 principles, and we'll just go through them one by one. And I know you like this kind of way of thinking about pain in a contemporary manner. So number 1, nociception is a system-based phenomena. What does that mean to you, Tim?
Well, importantly, it's what it means to me. I'm not an expert in pain. Obviously, we see people with pain, but I wouldn't claim to be the font of all knowledge in this area.
And I would just add that I certainly think of myself as a clinical pain researcher, potentially, in my research work, and not a pain scientist. I don't want to be a pain scientist, and I like to use that term in a derogatory manner for anyone that doesn't agree with me.
Okay.
So I'm not going to call you a pain scientist unless you say something that upsets me.
I would just call myself a clinician.
Yes.
So this is certainly a clinical interpretation, but after hanging out with a number of people that know a lot about this area, that has helped form that opinion.
Yes, some pain scientists.
Correct.
Yes.
So nociception is a system-based phenomenon, and we can keep that quite simple, that it is the whole of our system that is involved in this process. So it's not just the wiring of something in our skin to this decision that this is some sort of noxious stimulus going on.
Right.
It's more that how the whole system interacts around that, and that's very important when that translation comes to the interpretation of pain. So I think it's good enough to just keep it as simple as that we're talking about the whole of our system that could interact to, I guess, interpret this nociception.
Number 2, nociception is neither sufficient nor necessary for pain.
Yeah, I'll read that again.
Because you kicked the camera.
Yeah.
No, keep going.
So this is a one that probably takes a little while to get your head around. So nociception is neither sufficient. So basically, just because you have a noxious stimulus, that doesn't necessarily mean that's interpreted or the output of that is pain. So something that might stimulate the nociceptive apparatus in our system to arguably end up resulting in pain, that doesn't necessarily happen every time. So things that are often noxious to us over time, once we habituate to those type of stimuli, they might not be painful at all. So that's where it's not sufficient, but then we can have the other way around of that we don't necessarily need that nociception to occur for us to experience pain. And there's examples of that around people thinking about doing things and they get a painful response, or talking about a painful body part and they will be experiencing pain.
Yeah.
So we think traditionally of that nociceptive system equating to pain, and it doesn't. It's neither necessary or sufficient in some circumstances.
Yes, context. We talk about context a lot, and it reminds me of that Stellark, how we did a little bit of work with Stellark. People might know Stellark because he's a man that has grown an ear on his arm.
Yep.
And he is also well known for doing performances where he puts hooks in himself and hangs himself above different things as an artistic statement. And he's done that 30 times or so in his life, and to me that seems like something that would be quite painful, but he hangs himself up and is quite happy with that. Yeah. But then we did a series of kind of studies with him, or one study really, and we used the cold pressor test to give people pain, and Stellark had to put his hand in the icy water and was disgusted with himself that he could only last about 40 seconds. Yeah. And insisted that he would have to try again, and we were happy for him to try again because we thought his system might be wound up and he might be a bit worse, and he was. So context is a very important issue around this, I think. The nociceptive system becomes more efficient the longer it is active.
Yeah, this is a really handy one for us when we talk about pain sensitivity. And another term for that is efficiency. So it's like anything that we learn in our system. So if you're learning to ride a bike or play a musical instrument or play a sport, you get more effective or efficient at doing that. So it requires less thought process. For physical endeavours, it requires less motor neurons to perform a task, so around efficiency. And for want of a better term, our pain system, or our nociceptive system is more accurate, gets more efficient, and that can be helpful for us if what we're facing is a problem,
yes,
or it can be completely unhelpful.
Yeah. Okay, yeah, that's a good point. Next one. Number 4, pain is just one protective system. What's that mean?
Yeah, well, it is one. There's other protective systems. Obviously, immune system is a classic example of that, where that system's set up to protect our system from different bugs, for example. So we'll trigger an immune response, and that can also be important as part of the process of healing as well. And pain generally, in most instances, is helpful and it is protective. So if you've got your hand on a hot plate, then most of the time that's a problem, and you'll get a very efficient automatic withdrawal reflex associated with that to get your hand away from the danger. Same stepping on something sharp. So broadly, that system is designed to be helpful and protect us amongst other systems in our body. And as we're learning now, there's a lot of interaction between those different body systems that can have, I guess, cross influences on each other.
Okay. And the last point, management must consider biosocial cues that affect the brain's evaluation of the need to protect.
Yeah, we sort of mentioned this in the earlier point, but this is so important in our contemporary understanding of pain, where we used to think you've got a stimulus, you've got a response, or from a physio perspective, find the source of the pain, treat the environment around that, or treat the tissue structure itself, and then problem sorted. But as we know, many people with a very similar diagnosis present completely differently. So that must consider the bio part of it. Obviously, if you've broken your ankle, then the ankle fractures are very relevant and possibly initially the key part of management, so dealing with that. But then there's those psycho, which is the psychological, which we break down further into the cognitive, which is the thoughts and the beliefs, and the affective, which is the emotions, so that psychological components, and then the social components around that. So where we are when things occur, the different drivers or influences on our system. And often that's thought of as vague and complicated, but I think we comfortably refer to that as interesting now, because that's what makes each person's story individual, and it helps us, I guess, put that story together to understand what are the different factors driving that individual's problem.
Yeah, it does. And I think that we as physiotherapists probably understand most of these concepts these days. The patient might not.
Yeah.
It might be alien to them or not clear.
So that's true across certainly patients, depending on their background and or their understanding, but health practitioners certainly fall in that category as well.
Yeah. So that gives us a basis of understanding pain.
Yep.
And now I think we have a slide around pain sensitivity. And this is a diagnosis, a definition that we've kind of come up with. And it took quite a while, actually, to get some wording around this, and it might not be right or exact, but this is where it's sitting at the moment. So we've got pain sensitivity in the clinical context can be considered as a term used to encompass the phenomena that some people's experience and perception of pain is enhanced beyond that of others. And it's very vague in a way, but we couldn't come up with anything better yet.
Well, a couple of key points there you've put in the clinical context, because that's what we're really angling at the moment. So a person in front of us with a persistent pain problem usually. So some people's experience and perception of pain is enhanced. So what does that mean to you?
Yeah, I think that's the bit I find vague, but also kind of informative. And I guess it's hard to answer that in one word, but I think maybe that's something to come back to after we've travelled through these next few things to kind of see what that does mean, because as we know, by definition, pain is a subjective experience. To kind of call it enhanced doesn't make a lot of sense at that level. But I think when you consider all the things that we're going to discuss over this series, then that wording might make a bit more sense.
Yep.
That was a good politician's answer.
Yeah, you dodged that completely.
This is an excerpt from the Musculoskeletal transitional framework. I should know the name of it, but Tim knows the name of it better than me.
You might want to start that slide again.
Yeah, no. What's it called? I always forget.
Musculoskeletal clinical translation framework.
Thank you. Clinical again.
The fact that that's a problem means that we didn't do very well on the naming of that.
We haven't done very well, but again, it's harder to get a better name.
Yeah.
It is a mouthful. So in this framework, this is you can go to the website and actually download the
front page.
Yeah, that where this section on pain features comes from. Also, there's an e-book there that you could buy. We don't make any profits from that. It all goes to generation of the content for that.
Yep.
There's an app around now as well. But really here we're just picking out this part about pain features because that's what we're talking about here. The first thing I notice about this is it doesn't have the word pain sensitivity on it, which is the title of our talk here. If you Google things around pain and research around pain sensitivity is a term that comes up a lot, particularly around research into trying to define pain in more, I guess, well, psychophysical is the word, but something more than just a rating out of 10, specific testing around that.
Yeah.
So I guess it'd be good to see what you think around how this gels with the term pain sensitivity.
Yeah, this part of the framework is arguably the most complicated and arguably the most simplified as well.
Yeah.
So a lot of work went into this, and certainly Helen Slater and Peter O'Sullivan's input on this was very important as well. The first line, the types of pain shouldn't be a problem for people. They're just the internationally recognised and defined different three types of pain: nociceptive, neuropathic and nociplastic.
Yeah, we should probably quickly say that neuropathic is pain related to damage of the nervous system.
Yeah, damage or disease of the nervous system. Yeah.
And nociplastic might be new to people. And,
it used to be called functional pain or dysfunctional pain,
yeah.
But effectively when there's an absence of clear cause or triggering of the nociceptive apparatus, and also in the absence of neuropathic pain. So it's almost a diagnosis of exclusion, and we often consider different disorders such as irritable bowel or fibromyalgia as nociplastic types of pain.
Yeah.
And then within that, to be clear, inflammatory pain fits under nociceptive pain because it's stimulation of the nociceptive apparatus.
So sorry, I got you off track there, but I agree that those terms should be reasonably common to people.
So there's no debate there. Well, there will be ongoing debate, but they're the most accepted terms for now.
There's a lot of debate.
So the second part around the characteristics, that's a clinical term that physios would most often be familiar with, but not all health practitioners, but the concept of pain being mechanical or non-mechanical. So that's really the features of the person's presentation, where someone typically with mechanical pain, if they've got a sore back, if it hurts to bend and sit, and it's fine when they stand and walk around or lie down, then the amount of stimulus and the response to those are matched or equal, and there's clear also relieving factors. So that's mechanical. Non-mechanical is the other end, where it can be constant pain, where you can do a small amount of activity and then pay for that for 2 days afterwards, so it's out of context or out of what you'd expect from the response to a minor stimulus. And then also you can have the spontaneous pain even at rest, for example, with the non-mechanical end. And then the last one is sensitisation. So we haven't called that, as you've said, pain sensitivity, although that's arguably where this best fits, because it's not just about pain sensitivity. It's trying to help us think more broadly that our systems, and we talked about different systems in our body being protective, but different systems in our body could be sensitised that can impact or result in pain sensitivity as an outcome of that. Or there may be true, if we like, simple pain sensitivity, if there is such a thing. So we'll cover that in more talks, but broadly that concept, if the response to pain is sensitised or the system is sensitised, that could help guide us that this is a non-standard typical pain presentation that we like to think of as the black and white easy ones to deal with. And that's okay, just marking that this person has features of sensitisation can be really helpful for us to go, right, we've got to step back and look more broadly at the whole system, all the different systems involved in this.
The other thing this doesn't say is central sensitisation, and that's bandied around as a diagnostic term very commonly.
Yeah.
Comments on that?
Well, again, I'm not the expert in this area, but my understanding from a clinical perspective, we talk about peripheral and central sensitisation. They're recognised phenomenon in pain science, but clinically to be able to differentiate between those with the patient in front of us isn't possible. Arguably it's not that black and white, but also picking up that someone has peripheral or central sensitisation, A, doesn't tell us what's caused that sensitisation, and B, it doesn't tell us what we need to do about it.
Yeah.
So that's why if we step back and take the person's circumstances into account, so their story, as we often talk about, we can put together, okay, here's some different factors, and with that person, they might come up with the answers of these are the different factors that are driving my sensitisation, which gives you a real path to management that's very individualised.
There's two other things around this term, central sensitisation, that come to mind. So one is that it's a natural phenomena anyway that should occur when you have a painful or a potentially painful incident or an injury, where it's a normal process. So defining a disorder by a normal process doesn't totally make sense to me.
No. And that's just a quick example on that is if you have an acute injury, if you sprain your ankle, the tissues around there will become sensitised as a protective mechanism. So that's where, as you say, that's normal and helpful in a lot of circumstances.
Yes. And have you ever heard of somebody with chronic knee pain being told they have peripheral sensitisation as their diagnosis?
Well, I have on the odd occasion. But
I'm out of the loop and I've learned something from my clinical reasoning. But it's not so commonly referred to.
No.
I mean, in your explanation to the patients, you might say that, but you don't usually see that as a standalone diagnosis.
No, not as a listed diagnosis.
Yeah, exactly.
Not at all. You're right.
Yeah. Okay, so that's a little bit about the musculoskeletal clinical translation framework.
Well done, Darren.
And you'll hear more from us on that because we're going to do a series on that at some point. So just a few kind of closing questions almost here is like, why the focus on pain sensitivity? I think we've kind of answered that because we've seen that it's a confusing issue for clinicians, and we've kind of been on a mission to change that confusion or to improve people's understanding of that. It also, we deal a lot with people that are not medically trained but involved in part of a medical team, such as insurance workers, and really, as we said with patients, they don't necessarily understand the current concepts in pain. So we've been on a mission to educate those people about pain as well, and we just see it as really important that they understand that to operate in this world and dealing people with pain.
Yeah, well, pain sensitivity or sensitisation is an issue for a lot of people, particularly with persistent pain. And if they don't understand it or get it, or the healthcare practitioners don't, or other people around them don't, then we've got a problem, given it's readily recognised, at least in certain academic and clinical circles, that this is a major barrier for some people in terms of their persistent pain.
Yeah. And in the end, that's kind of one of my main reasons why I like that term, pain sensitivity, because it's understandable to the average punter. And it's understandable to people that aren't medically trained, and it kind of explains what it is.
Yeah, and we've played with that with patients in the clinic in lots of different ways, and we can talk about that a bit at a later stage. But that's been very useful for our clinical translation to patients, I think. Yeah.
So I think we've answered the first question and the second one there. Why do we want to talk about it? Because we want to educate people on this.
Yeah.
What makes us... Well, who made us the experts on this? Self-proclaimed, that's fine.
Yeah. And look, I don't think we ever promote ourselves as the experts, but we've hung out with lots of smart people, as we've said. We've worked with this concept clinically for a lot of years now, and I think we've adapted our understanding and thinking over time, and we're open to that changing, because what we're saying today, knowledge will advance on that. But that said, you'll talk about some things later on where this knowledge has actually been around for a long period of time, but people just weren't listening.
Correct, yeah. And really we're not experts in pain, but we are, better at translating research to practice. So that's...
Yeah, we have a foot in both camps, which helps.
Yes.
Yeah.
Great. Okay, this is our new feature from listener feedback. Unfortunately, they didn't use their education@painoptions.com email address to provide that feedback, but it was verbal. But here we are. We have a paper of the day. There is a Latin term for paper of the day. How do you say that, Tim?
Yeah, thanks for throwing it to me, Darren. I'll just bounce that straight back to you.
Well, it's there. My Latin's not very good. I didn't learn that at Gosnell Senior High School. They didn't have Latin.
Maybe someone can send us an audio recording of them pronouncing it.
That would be good.
It could be entertaining.
So we do have a paper of the day, and this one is a paper by Joe Niche. Did I say that right?
Probably not, but someone can email in and give us a recording.
Sorry, Yo.
Yeah.
We have met you once or twice, and I remember that he owes me a glass or two of sake, I think.
Very good.
I've got this quote that I'm going to ask you about, Tim. The presence of neuropathic pain does not exclude the possibility of central sensitization pain or vice versa. In fact, some patients evolve from neuropathic pain with severe but local signs and symptoms to a more widespread condition that cannot be explained by neuropathic pain solely. In such cases, central sensitization might account for their evolution to a widespread pain condition. So this is around that concept of neuropathic pain and pain sensitivity, or central sensitization as it's being termed here, and the interplay of those factors. Because in the community and in medical reports, we see it all the time that people use these labels interchangeably. We've defined them earlier, and they're not the same thing. So there's confusion there, but the processes are similar in a way, that the output to the system is similar.
They are, but again, what that means for each person is very different, and it doesn't infer a typical path of management will be helpful. And we know that because clinical practice of helping these people is broadly not black and white and not clearly successful.
Yeah.
I think that's very important, because you can have someone with neuropathic pain, and a good clinical example would be radiculopathy. So let's say lumbar radiculopathy, where there's actually been some degree of damage or injury to the nerve root. And because of that, you'll get symptoms in the distribution of the peripheral nerve.
Yep.
The nerve root, let's say S1, for example. And because of that testing and then the location and features of the system, that could be quite clear neuropathic pain. That person could then actually go on to develop more widespread leg pain, which isn't arguably the neuropathic pain.
Yes.
So you could have both of those things going on. And you can have the converse of that, where you have someone with symptoms that aren't typical of neuropathic pain, but are more of sensitization, be that peripheral or central. So understanding the differences, but then trying to match that with each individual case, I think, is the key.
Yeah, agreed. Okay.
And that paper's probably some better science behind explaining that than what we might.
It's a good summary of the research aligned to the 5 points that we spoke of Lorimer's before, and in general for anyone working in musculoskeletal pain, Greaves' modern musculoskeletal physiotherapy is more or less not to offend anyone, but Bible of sorts, and you can fully recommend that text. Great. So any questions, Tim?
More around pronunciation, but we'll wait for them to come in on the email then.
Yes. If you do have any questions, please email us at education@painoptions.com.au. I think that's all for today.
Yes.
Thank you very much, and we will see you another time.
Thanks.